So this morning's tutorial is on the nervous system, and it's on the history taking. Traditionally, students have found neurology difficult, and I think for good reason. We could summarize the problems that they have is, number one is knowing what to do, and then the second thing is learning how to do it, and then understanding what it all means. If you look at that more carefully, there are a number of competences there that students have to acquire. One is knowledge, the knowledge of the nervous system. Now this applies to all systems. And if you think about knowledge, mostly that is self-acquired. In other words, you acquire it yourself. You get your formal lectures and you read. So the knowledge base really is the responsibility of the students. The skills in neurology have to be taught to you by somebody who knows the skills. And as we say, skills are very different to knowledge. And the paradigm, we say, particularly in neurology, is the skills are taught, then they're practiced by the students, and finally the experience of your practice begins to what we call solidify the actual skill. As we go forward then with history taking, we're dealing with the same principles as in any system. 1, history; 2, examination; and 3, what we call what it all means. Now, history taking is going to become self-evident as we go through it. The skills we will talk about in a minute. But there is something particular in the nervous system in that the history and the examination together often localize the site of the disease. That's probably the most important point I'm going to mention this morning. In other words, you're always using the history and the examination to help you to localize where the disease is arising. And it's from that point that we begin to think about what might cause it. So going back then on the history, or the neurological history taking, there are a couple of things that are worth mentioning again, that you do have to be a good listener. I think particularly in neurology, although it applies to all of them, because the nuances of what the patient is saying come across in the history. The second point I want to make is this question of interest and sympathy. Sympathy and interest actually are very important in any doctor. These are qualities, or any medical care person. But we do emphasize them, and particularly sympathy. Patients pick up on that very quickly. And the other thing in neurology is that often is the case, you can see the abnormality as you're taking the history. If somebody has an obvious paralysis on one side, or an obvious cranial nerve palsy, or perhaps some speech disorder, it becomes obvious during the examination. And that happens. It's worth emphasizing that that actually happens as part of history taking. So what is more specific then about neurology? Well, we often determine handedness, because that is going to determine which lobe is dominant. Now, most students know by now that the left lobe is dominant in 95% of us, and we are right-handed. But that is important when you are going to interpret the physical findings. For example, right hemiparesis is often associated with the speech abnormality because the speech area is involved. After that then, the history becomes rather like any other history. You lead off with an open question: what is the problem? You allow the patient to tell the story. I always write down the history as it is happening, and I use the chronological method. In other words, please tell me from beginning how it started, how it has progressed, how is it continuing, is it getting better, getting worse. The way I start the history is I often let the patient tell me the presenting complaints in a row. What has gone wrong with you? I have a headache, I fall down, and my left side of my body is not working. There I've got 3 main presenting complaints. My task then is to flesh out those 3 presenting complaints. Ideally, I don't like any more than 3 or 4 to work with. I tend to ask for the main ones at this point. And I do determine their order of importance. In other words, I often ask the patient, what is the main thing that's gone wrong with you? And of course, they'll tell you. Now, when it comes to presenting complaint, we actually know, and as the students I think now know, that there's a list of things you have to ask about each one. We could go through them for you just to remind you. Then there is the character or the nature is the essence of the complaint. What is it? That's the most important thing. Obviously, where is it arising from? How bad is it? In other words, how severe is it? That comes across. Then you're into time course, which I've mentioned to often enough. Its onset, its progress, its duration. And then exacerbating relieving factors, associated factors. Has the patient ever had it before? And if the patient has had it before, what was it like at that point, or has it changed? Then we move on to the next part of the history. And this is where we often do what's called a neurology systems review at the tail end of the history of the presenting complaint. It's a good time to tag on all the questions about the nervous system. The way I do it at this point is I remind the patient of what they said. So you have told me that you have headache and that you've lost power on your left side, etc. And the patient then is reassured that I've listened to his presenting complaint. And I often ask, is there anything else you'd like to tell me before I move on with some further questions? Then moving on to systems review. You've done this again with me many times. I think they're simple to remember, the questions in neurology. Remember, if you think about the function and just ask the question about it. You begin with motor function, for example. Have you lost power anywhere? Have you lost sensation, feeling anywhere? I often tag in bowel and bladder because I tend to associate power with limbs. Have you lost any impairment of bowel or bladder function? Then go on to pain, which is headache. It could be pain at another site, like in the face or in the back or in the limb, but it's pain generically. And then you have the big one, loss of consciousness. And the ones probably we add on because you've got specialized function which we're all using. Vision. Is your eyesight okay? Is your hearing okay? And occasionally we will ask about smell and taste because these are the specialized sensory functions. But in principle, we don't like asking more than about 7 or 8 main questions in systems review. It's a routine designed as a catch-all for symptoms that might possibly be missed out. Moving on to the next part of the history taking is past medical history. And then we have the same paradigm: past medical history, family history, social history, drug history, allergies. Now, is there something particular in the nervous system about past medical history? Of course there is, specific for neurology. For example, with epilepsy, there may be a risk factor there, like a head injury or an infection in childhood. The stroke with hypertension or diabetes or some other illness in the past. So again, we tabulate the main, what we call issues in past medical history: illnesses, operations, hospitalizations, and their chronology, and any relevant symptoms. Family history, I think you know that we record first, what we call first-degree family relatives, and you know what they are. Parents, siblings, and children. We're interested in neurology often in genetic diseases at this point. For example, we see epilepsy actually runs in families. There are some specific diseases like, I'm thinking of, say, Huntington's chorea, which is autosomal dominant. We see muscular dystrophies, the different types of them. So we do ask about where it is relevant. And moving on then to drug history, we tabulate the drug, the dose, the duration, and are there any allergies or side effects. More specifically then, I'm just reminding you about the key points of neurological history: establish good communication, allow the patient to tell the story, ask questions in a logical order, and listen to the answers. It's often better to get the patient's description of what is happening than your interpretation of it. And that's why I tend to write down what the patient says, rather than my interpretation. Of course, that has to be short, brief, and to the point. You observe the patient during the history taking, and all of that leads to something in the doctor's or student's head. That is a hypothesis you're always working with the likely thing that is going wrong. So you're amalgamating the symptoms as you get them and already building up hypotheses about what has likely gone wrong. Yeah. So moving on to what's called the neurological examination, and this often starts with the student observing the patient generally. Now, this is a very big area because it involves the patient's level of consciousness, which becomes immediately apparent to the student. Is he fully conscious, or is he what we call comatose, would be a good example, or maybe just confused. In other words, disorientated. So this immediately becomes apparent to the student, and that is often the first major observation, normal or abnormal, I call it. The student may also observe the patient's what we call appearance and behavior during the interview. For example, the appearance and behavior may belie an organic disease, for example, or it could be just self-neglect, social, or it could be psychiatric or even cognitive in origin, i.e. arising from a dementia or a psychiatric disorder, and this will become apparent. The student may observe abnormalities immediately in speech or sometimes in movement, or even perhaps in the way the patient gets in and out of bed or gets into the examining position. During the interview, during the observation, the patient, you may observe what's called the patient's higher cerebral function, the memory, and learned abilities. This is more likely to become obvious during the history taking, but immediately on, as I say, on examination, these may become apparent to you. Similarly, the patient's mental attitude, their attitude towards you, and this obviously is going to involve the patient's mood, the patient's concern, the patient's insight. Now, the only reason I say this is moving on is that the examination of the nervous system diverges at this stage into physical examination. And physical examination for a medical student usually involves cranial nerves, upper limbs, lower limbs, and gait. If there's an obvious abnormality in the area of what we call patient's mental health or patient's cognitive health, or what we call the level of consciousness, then the examination moves in those directions.